As a physician, especially in private practice and in the US, I would say more so than other countries, you're being tracked by how much value you're bringing to a hospital healthcare systems, whether you're consciously keeping track of it or not. Some healthcare administrator is. Unfortunately, the current system is not rewarding prevention.
For example, as a PCP, let's say you prevent a stroke, the only financial benefit is just that one visit you had. But if they had a stroke, the interventional neurologist would make so much money from taking out the clot, but the PCP would get nothing, right?
It's better to prevent and prepare than to repent and repair.
There was a patient I had, and she was really sick and she was young and she was in the hospital for months. So I was pretty much seeing her every week I was working, really dealing with her husband a lot. She finally got discharged and I happened to run into him probably like 6 months later. I asked how his wife was doing and unfortunately she passed away. But he was very thankful for the care we provided.
AI and automation is going to continue to get integrated into the healthcare system. So whether we're using AI more kind of in the ER setting as triage for vitals and see who's more critical and sending us alerts and so forth, and documentation. Documentation, hopefully for us, becomes easier. The way I kind of see this playing out, let's say in the next 5-10 years or so, is we'll start with Dr. Michael Ionetti first.
Hey, thanks for having me on. I'm Michael Ionetti. I practice in Charleston, West Virginia. I'm an academic physician. I do mostly inpatient medicine, and I have an experience as a hospitalist practicing in a private community setting as well as the larger academic setting. Fortunate now to be an associate program director with the residency, so I get to work a lot with residents and medical students, in addition to providing mostly inpatient medicine.
Dr. Sohi?
Good morning. I'm Sajid Sohi, and I've been practicing in a private practice setting, hospitalist and primary care for the past 10 years or so in a suburb of Phoenix called Goodyear, Arizona, and enjoying seeing patients both in a hospital and a clinic and keeping that traditional model alive of internal medicine and enjoying all the challenges and opportunities that it brings.
Very good. So we have a nice panel of experts here. I myself am a practicing cardiac electrophysiologist. I've trained in internal medicine. I did my training in general cardiology, and now I'm currently a practicing cardiac electrophysiologist in the northeast of the US. Michael, what would you say is a typical day for you like as a practicing internal medicine specialist? Average patient census, what's your average schedule like? How's that broken down for you?
So because I supervise residents and I'm an associate program director with the residency, a lot of my time is spent supervising residents. And then I get some administrative duty. Over the course of a year, I'll do about 10 or 11 weeks of inpatient service or inpatient wards. And then when I'm on the inpatient service, we like to make sure we allow enough time for educational activities. So I'll see probably 15, 16 patients a day or so. And then I'll be in the hospital maybe 8 to 4, and then we'll take call on our patients at night. But the residents handle most of the calls, so I'm rarely called. And then when I'm not on the inpatient service, I'll have probably 1 to 2 half days supervising the residents in their clinic. And then the rest of that time will be administrative time, be it interviewing future residents or doing a little bit of research with the residents or preparing lectures, but a lot of academic and teaching.
Perfect. And how would you say that's broken down in inpatient versus outpatient? Are you doing?
Yeah, so I would say probably, half my time is admin time, and then the rest of the half, probably 40% is inpatient, maybe 10% is outpatient.
Okay. Perfect. So it's a good mixture of everything there in academia. What about you, Dr. Sohi?
Oh, yeah, so I'm in a little bit different setup. I'm in your traditional kind of frontline hospitalist and primary care setup. So in this traditional practice, let's say you're a hospitalist week, you'll be starting typically like 7 a.m., picking up your patient list from the night shift team. So we would pick up the patients, as you know, in the morning time. First half of the day, you're taking care of your existing patients, the issues, the follow-ups, coordinating care with the consultants and the case managers. And the afternoon is more for the admissions and things like that. So as you know, being a hospitalist, you'll probably be there till the early evening, at least by the time everything is wrapped up, unless you're not on call or something.
Very good. And how is your inpatient versus outpatient day structured? Are you like 2 weeks inpatient, 1 week outpatient, or how's that?
Oh, correct. For every group has their own setup. For myself, I do a week of being a hospitalist and then 2 to 3 weeks of being a primary care doctor. So just kind of keep skills on both sides so I don't lose one side.
For myself, so being a procedure list more or less. My days are structured in the sense of we have about 2 lab days a week. So in those lab days, we're in the hospital doing procedures, whether it's ablations or pacemakers. And the rest of the 3 or 4 days remaining, we're either rounding on patients. We cover 3 different hospitals, at least I do, and or seeing clinic patients. For me, an average clinic day usually encompasses about 18 to 24 clinic patients. And a typical procedure day, we're doing 4 or 5 procedures in a day. I would say my average time is in the range of 7:30 a.m. to about 6 p.m. or so. Regarding weekend call or anything like that, I would say I work 1 in 5 weekends or something along those lines. So that's how it's structured out. I know some hospitalists are structured 2 weeks on, 2 weeks off. And then I would say for me, it's something like 2 weeks on and 2 weeks on. I'm just kidding. We do get weekends off often, but we don't have dedicated weeks off, at least in my practice. And that's pretty common if you're a gastroenterologist, neurologist, cardiologist, etc. So now we have a rough idea of how an internal medicine specialist in the academic world or an internal medicine specialist in the private world, how it's structured, inpatient versus outpatient. Dr. Ianetti, what would you say is the most rewarding part of your medical career? What brings you the most satisfaction?
It's definitely the teaching. I enjoy mentoring students and residents and just seeing them learn and grow. A lot of times we'll see them come in as a third-year medical student and just be completely new to the whole hospital and what to do. And then, a lot of them will stick around for our residency, and then you see them by the time they're graduating, and now they're really fully functional, very competent doctors that you'd be, thrilled taking care of your family. And just to see that growth is truly something special. And that's really what I enjoy most in coming to work. And, in addition, I really enjoy the team atmosphere, having a senior resident and students and interns, and just how we all work together for the common good of taking care of the patient and learning together. So for me, it's definitely the teaching side.
Perfect. And I'm sure in rare situations, you're probably surprised a little bit. What, we're letting this guy graduate? What? How?
It's a lot less than you would think.
What about you, Dr. Sohi?
That's always a good question. So for me personally, I think that there's probably two aspects that give the most enjoyment. One is that, of course, as a primary care, preventing something from happening, like a theoretical risk to the patient, because everything's theoretical, right? For a patient who has uncontrolled blood pressure or diabetes, that you did something right for the patient to prevent something from happening. That's the one kind of joy. But then also another kind of joy is something has happened to the patient and preventing further complications. Like you saw a patient in the hospital who had a stroke, but trying to be part of that care process to prevent it from happening again also has a different type of value, but that also has a joy. So I say preventing something from happening and preventing something from happening again is probably the two different kinds of joys that you can get from working on inpatients and outpatient side.
And the other question I have for you guys is we're seeing a increase year by year of APPs, advanced practice providers, dramatically, at least in the US. I would say in other countries like Canada, European countries, Australia, Asia, etc., this is less noticeable there. There are some APPs in Europe and Canada, for example, but in the US, it's just a very wide and dramatic influx of whether it's physician assistants or nurse practitioners. And when we look at the statistics, they have really increased from, let's say, 2012 until 2021 or so. How has this increase in APPs affected your day-to-day practice in terms of how things are being practiced now versus how things were, let's say, 10 years ago?
Well, on the academic side, maybe we're a little bit less affected, but we certainly deal with more APPs as far as subspecialists. A lot of times we won't talk directly to, the cardiologist or gastroenterologist. If we have a question, we'll talk to the APP. I know when I was a hospitalist, APPs were really helping us see more patients and such. And I know a lot of the hospitals I've worked at have changed their bylaws, which is what APPs are allowed to do, to where APPs, when I first started, were required to be supervised for every encounter by a hospitalist or physician. And now definitely a few of the hospitals I've worked at have almost granted APPs the autonomy in seeing their own patients, at least for more daily progress notes. So they're definitely, taking a more prominent role, which is good and bad. On one hand, there is a shortage of physicians, and, it definitely helps the subspecialists maybe do more procedures and be more efficient. It helps us be more efficient. But at the same point too, you wonder if in the future that they may be taking more of our roles and maybe don't have quite the training we have.
You guys may be aware there was a study done at the VA healthcare system. This just came out like a couple of years ago, I think, where in the VA, in the ER setting, they had NPs sort of practice independently without physician collaboration. And it's kind of interesting what it showed that in that particular study, at least, was this care by nurse practitioners actually led to less favorable patient outcomes from the ER perspective. So each patient stayed in the ER longer. They found that each patient also had more financial costs per patient and overall sort of less favorable patient outcomes, that they would be discharged and they would come back sicker and things of that nature. So in my practice, the inclusion of APPs and the growing number of APPs that we're using in healthcare, I think this is crucial and I think this is very helpful. We rely on them for a lot of primary care things, from a specialist standpoint, from procedural standpoint. But I think that is also with some kind of caution because we're collaborating with them. But I think at the same time, we have to be sort of careful with the responsibilities that are being shared.
It's a very important topic, especially for the upcoming future doctors. One thing is we have to look, unfortunately, in healthcare in this country, we always have to look at stuff from a financial perspective. And as the time goes on, if you look at most fields like hospitalists, emergency rooms, primary care, there's less and less physician-run companies. Most of the time, they're becoming from nationalized staffing agencies or private equity in this structure. So will doctors get short end of the stick because they're now viewed more not for your technical skills, but are we considered on the balance sheet by these companies? Are we an expensive laborist? Right? For example, your field, you require technical skills to do electrophysiology. But what about general cardiology or general internal medicine where you're not doing a procedure? When these people, the MBA people are looking at the balance sheet, oh, this guy sees around the same patients as a APP for this much more money. Why can't we get 1.5 of an APP or something like that? So it sounds so cruel to say, but sometimes financial realities are driving staffing decisions. But another key interesting point for doctors is that there's so much work in every field. It doesn't matter you're in a big city, you're in a rural area, academic center, or private center. There's more work than there's available for doctors. So is it going to be the future doctors or current doctors can do more and more work? There's only an X amount of work that people can do. So the APP growth will only continue, and I would only think that the scope will increase. Like, I don't remember 10, 12 years ago even hearing about CRNAs and things like that. So now they're basically the anesthesiologists several places. And I wouldn't be surprised in other fields like gastroenterology, maybe the EGD and colonoscopy will be done by the MP and the complex ERCP by the gastro doctor, or even cardiology. Diagnostic cath could be done by the MP in the near future. Only your complex ablation will be left for yourself. So, the world keeps changing. But I think one thing is that the amount of workload is so high and the amount of workers are so low. And then with a lot of doctors not pursuing that old school way of life. Like, for example, there's nothing wrong with it, but as the generations are changing, not everyone wants to work every day in the hospital. And there's more value on work-life balance. So there may be a lot of doctors out there, but there may not be enough people to do the work every day. So the rise of AI and APP will only grow. The doctors that are kind of every human has a little bit of an ego and they want to protect their field, but you got to understand that the advanced practitioner revolution, like with AI and all these technologies are coming, and whoever embraces it will survive well. If you're going against it, you're going to be left behind.
Exactly. I think that's a good point about the financial side of things. Like, let's say if you're an MBA administrative person and you're running a cardiology practice, is it better that you hire a general cardiologist for, let's say, $350,000 per year, or do you hire two NPs for $75,000 each?
Correct.
Right? So I think that is kind of the decision making that is probably going on, and that needs to be done very carefully.
Yes, and the other interesting thing is that I always found a funny comment to say. For example, let's say if we were advanced practitioners, let's say I started my career with gastro and I didn't like gastro, that I could pick my next job as cardiologist. But if I said I'm a cardiologist, I'll be going to jail, right? Because I can't misrepresent myself. I can't change my field that easily. But it's very interesting that they have a lot more flexibility, so they can fill in the gaps much faster. Than doctors. So doctors, by the time you do residency, fellowship, subspecialty, this is a multi-year investment. So you can't just hire a cardiologist tomorrow, right? So APP can fill in gaps much faster. That's the advantage.
Exactly. So it's 2 years of, for example, PA school.
Yeah.
After that, you go work in a dermatology practice for a year. You don't like that. You go to a cardiology practice. You don't like that. You go to primary care. So it's very flexible, which is kind of good because it gives you more options if you're the PA. But at the same time, if you're replacing kind of that two PAs versus one physician example, then you're definitely not as experienced as the physician in that field who has been training in that field for years, essentially. So yeah, that's an interesting point. Yeah, that they can just turn tables whenever.
I do hope patients maybe have a preference too towards seeing physicians most of the time. I know from my perspective or a family member's perspective, I don't think you mind seeing a PA sometimes or if they're helping a doc, but if you would only see a PA, I still think you probably would prefer to see a physician. I hope that administrators think of that, when they're trying to recruit more patients and such, and looking at the financials from that standpoint.
Yeah. And then also on this important topic, it's not just the APPs themselves. Actually, sometimes specialists have pushed this as well because they're leveraging their time. So I'll give you a good example. As primary care, you may refer a patient to a cardiologist or a gastro or orthopedic, but the low revenue visits of the actual visits are done by the advanced practitioners. They're only going to see the specialist in the operating room. So they're leveraging their time. So it's not just their fields themselves have kind of arisen, is that the specialists are also very much leveraging their benefit of per minute of revenue creation by advancing this kind of change in structure.
Right. That's a good point. And I hope this is not happening. But I fear what may be happening in certain practices is, let's say you have a big practice, you have thousands of patients and so forth, and your doors are open for all kind of patients, that certain patients with sort of better, quote unquote, insurances that the physician's seeing versus people on Medicaid or something like that, those visits are being, seen primarily by the APPs, which, of course is problematic. But I can see that being played out in certain scenarios, but I hope that's not.
Well, I know in rural West Virginia, there's such a shortage of providers that the only person that might be in that community to see the person is the APP. And again, you might not be able to attract a physician there with the payer mix of the insurances and the low volume. So they are providing a needed coverage to a group that, needs someone to take care of them.
Right. And the physician shortages that we're seeing and we're expected to see going into the future, let's say in the 2030s or so, that of course is a concern. So we do have to collaborate appropriately with APPs. And the biggest shortage that will be felt will be primarily in kind of the rural settings. With the big beautiful bill, those rural hospitals, those rural centers will really kind of feel the hit, unfortunately. So that is, something as healthcare physicians we have to be mindful of. And I think the impact will be felt more so in the rural environments compared to, let's say, if you're in Boston or New York or LA or something like that. One question I have for you guys is, what are some of the biggest challenges that you guys are facing currently in inpatient medicine? Is it EMR related? Is it staffing shortages? Too many patients per physician? What would you say are some of the biggest challenges you guys are seeing in hospital medicine currently?
Yeah, so right now, the thing that jumps to my mind is patients who maybe need a place to go once they leave the hospital to go somewhere to get some physical therapy or to get medicines. We have a big shortage of skilled nursing facilities. So while we're waiting for a patient to go to a skilled nursing facility, it might take a week for them to go, and then they just sit in the hospital essentially. And then along the same lines, when we talk staff shortages, lack of social workers, case managers, things along those lines. Again, I'm a little bit protected because I'm on the academic side. So, I know in previous jobs, the challenge was maybe productivity and trying to manage seeing a large volume of patients and at the same time providing high value care. But I am fortunate enough now that that's maybe less of an issue.
What about you, Dr. Sohi?
I think the main challenge is probably similar for all the hospitalists across the country in general, is that a lot of the external forces that you can call it, that's probably the best, nicest, polite way to say, is that a lot of doctors generally feel frustrated that the metrics of your daily activity, there's no metric or statistic that's been driven by the physicians themselves, right? So some external group of or individual says, like, these are what our facility or a goal or metrics, or you have an X, let's say every hospital has their own little policies and procedures, and they may be different everywhere, but the general themes of like things like coordinating your care and waiting for the insurance companies to make a decision. So it's kind of like hospitalists are generally the face of the healthcare system. So you're trying to explain to families, oh, we have to wait for your insurance to say this, X, Y, Z. So it's kind of like nameless, faceless entities that directing everything, and the hospitalist is the face of that. So sometimes people may feel the brunt of a system, right? That's probably the main issue for hospitalists across the country, is that insurance authorizations, length of stay, and all these kind of metrics that were never taught to you in medical school, but become the driving force of your behavior, unfortunately.
Yeah. Being in the private space of things. So I covered 3 different hospitals. The 3 different hospitals have 3 different EMR systems. Each EMR system has its own complexities, its details you cannot overlook, and so forth. So learning the 3 different EMR systems, plus our clinic is a different EMR system. So that is not anymore, I would say, but that can be challenging, especially when you're starting off. So that's a little bit frustrating, especially in the private space. Besides that, I would say one of the kind of annoying things is prior authorizations. So let's say you have a patient with symptomatic atrial fibrillation, keeps having bad palpitations, shortness of breath, etc., and you're trying to set this patient up for an ablation. They have failed multiple antiarrhythmic medications and so forth. And because of the kind of insurance this particular person has, they are not eligible for an ablation in this certain community or city or whatever. So just because they don't have quote unquote a good insurance. So that can be frustrating sometimes, just because the certain healthcare hospitals or centers, they won't accept certain kind of insurances. So that creates a challenge when you're trying to do what's best for this patient. And then you have to refer them to maybe out of state or something like that so they can get the best care that they need. Or let's say this patient needs an event monitor or Holter monitor because they're having palpitations, and the insurance company denies it and they want a prior authorization. So now you're stuck on the phone with the different kind of physician for half an hour trying to convince them, hey, this patient really needs this test because of X, Y, and Z. And that half an hour, 45 minutes, whatever you wasted trying to convince this other person who's, from the insurance side of things to try to counter your decision making, you could have spent that 30 minutes taking care of another patient. And, so that's kind of frustrating sometimes. So that sort of my grievance with how things are a little bit, unfortunately.
I can add on to that with the insurance companies. For us on the hospital side, there's inpatient status for patients and there's observation status for patients. And insurance companies always want to pay observation status for patients because it's a lot less expensive, and hospitals always want to have them as inpatient because they'll get better reimbursement. So there's always this battle to try and justify why you're putting a patient in inpatient or obs. And, you're talking to these insurance company representatives and trying to advocate for the patient. But it's definitely time consuming, and you could probably spend your time doing a lot better things or more productive things.
Yeah.
Correct, yeah. Yeah, I agree. No, that's a very challenging process for primarily in the outpatient side. Is that the best word, and I like to use for this prior authorization is opaque is probably the best word. For example, let's say you have 2 insurance companies and there's a medicine in one class, right? Let's say SGL2 or GLP-1 or whatever example you want to use. And there's 2 products. One insurance will cover one and the other insurance will cover another. And the only way you find out is with your experience of getting rejected from this company and that company. And there's no easy way, like electronic medical record. It won't say up for you, this is this insurance will cover this one, this insurance covers that one, and you only learn after the fact. So the really disappointing thing is that you may tell the patient, take your time, energy, effort, say, this medicine is the latest one for your disease process, so you will benefit from this. And then when you prescribe it, is that first you have to, I always disclose the patient, first you have to see if it's covered. That's one thing.
Yeah.
Coverage is only one part. Then another thing, is it affordable? Is it a $500 a month process or free for your coupon, or $10 a month? So there's so many different variables. So the patient comes to your office, you explain, you take all this time, energy, effort to explain something. And when they go to the pharmacy, they get a rude awakening. And then their frustration goes to the office that, you guys told me this medicine. Can you do the paperwork for it? And you could do the authorization. Doesn't mean it's going to be covered or not. So I think they make a system legalized in such a way that a lot of people get frustrated, unfortunately. I just wish that with the leverage of technology, they would be done in real time. That's all. That would be much better.
Exactly. 100% agree with that. So we see that, especially in branded medications realm. So whether it's diabetic medications, whether it's your heart failure medications, whether it's certain cardiology, GLP-1 analogs, and so forth. That's the frustrating part. You put this patient on a certain medication that's, helps with mortality or symptoms or whatever for heart failure, for example, and their insurance doesn't cover it. And you've convinced the patient, hey, you really need this fourth medication, let's say for heart failure, because this improves mortality, this helps your symptoms, heart failure, hospitalizations, whatever. And the patient's, okay, fine, doc, I'll take this medication. Then they go and you find out this is not covered. And then they're coming up upset because they didn't want to take the medication to begin with. You had to convince them, because for something like heart failure, they really need to be on, let's say, 4 different types of heart failure medications, for example. And now the medication you convince them of taking, it's not even covered by the insurance. They have to pay whatever, like $600 per month for this medication. And then you try the alternative medication and that's not even covered. And you're like, oh, okay, we can't do anything. So that's kind of, that's a frustrating part. I think that frustration is felt both in the primary care world, whether you're endocrinologist, whether you're a cardiologist, heart failure specialist, whatever. So that is there, unfortunately. And I don't know a good way to get around that. Maybe if in the EMR system, somehow they give you a prompt, hey, because of this guy's insurance, he hasn't met the deductible, this medication is going to cost him this much per month or something like that. So you can factor that into your decision making when you're trying to assess whether or not this is the right medication for this patient. Hopefully, now, as we're incorporating, AI into healthcare and the hospital setting and so forth, that may ease that frustration. I just haven't seen that yet. But yeah, hopefully that changes. And if someone listening works for Cerner or Epic or whatever, do take that into consideration. So what do you guys think about AI or automation showing up in the healthcare setting? How has that impacted your current practice now compared to, let's say, how things were 10 years ago or so? Dr. Ionetti?
Well, right now, it certainly helps gather information. If you have a clinical question about what medicine might be the best, it's easier to look it up and find a good journal article. And, we use Open Evidence or ChatGPT. I haven't used this yet, but a lot of my colleagues are using AI to generate notes, especially in the outpatient setting. To me, that just sounds wonderful when it comes. Or, if we use it to generate inpatient notes, I think that can be a big help. I think those are kind of the areas I've seen it help so far.
What about you, Dr. Sohi?
Correct. I would share similar views that the tools are there, but you can call them like first generation tools. So, so actually, me personally, I use them as just to see how the technology and tools could help me. But in my day to day practice so far, I have not used them, but I've tried them out a little bit, just waiting for them to be formalized a little bit better. But definitely, it's a very good aggregator of information, because our job, especially as non-proceduralists, is an information analysis job, right? So it does a very good job. So if you put lab values, ask it to interpret things, it's kind of amazing. It itself is almost a doctor level amazing technology. You've probably seen the news out there, how they did so well on the USMLE, things like that. So it's
that was
kind
surprising.
of amazing information out there. But I'm definitely a big proponent of technology. So I think it's definitely going to leverage healthcare providers. So this might be one of the key things that comes up, with the less people to work in the future. I mean, AI is going to be a huge help. Can you imagine that how much information AI will be able to leverage? All the we spend so much time doing things like, even though we're in the year 2025, how much time we do things like pre-rounding, all the stuff that was from the paper chart era. That's what we do in the computer era, right? Everyone takes so much time to do pre-rounding and post-rounding in the afternoon. If AI could do that, you just come at 7 a.m. You have the piece of paper or in front of your screen, all the pertinent stuff. You can imagine how much for your productivity will be leveraged in positive ways. So-called scut work is going to be gone, right? All the stuff that, first residents, interns used to get that paper chart had to find the physical chart. Then you're doing it for an hour on the computer every day. But soon enough, I'm sure these EMRs will have modules in it that you'll just come and right there, the summary is right there for you. So I think it's going to be leveraging us in positive ways.
Exactly. So I remember when I first started residency many years ago now, that when we started residency, we were using paper charts. And, you come at 6:30 a.m., 7 a.m. into the hospital, and you're going to the charts to see what the consultants from the previous day had written. You're trying to decipher their scribbles and trying to make sense of it in the paper chart system. But after 6 months or a year into my residency, I remember that we shifted to EMR, electronic medical record system, and that was definitely a game changer. And this is something that kind of transformed medicine in the past 10 years or so. And now you can actually intelligibly read what the consultant has written. So this has definitely been a blessing. Regarding automation and kind of AI incorporation in the modern, at least cardiology practice in my world, is previously patients had to come to the cardiology office every 6 months, 12 months, 3 months, whatever, to get their pacemakers or defibrillator devices interrogated. I'm making sure that they're functioning appropriately, the battery life is good, and so forth. Now we automatically get remote transmissions from the patient's pacemakers or the defibrillator systems every 3 months or so. And it'll alert us if there is kind of lead issues with the device, if the battery longevity is too low, or if the device has detected any arrhythmias. So that's definitely a game changer, at least in the cardiology world. And same thing now with these, smartwatches. They're able to detect atrial fibrillation, and that's more referrals for me. So I can definitely see how, AI and smart technology and automation will continue to sort of evolve going forward and make our lives easier, hopefully, and streamline and smoothen the process. And there's also some dictation softwares now that you just walk into the office and you have this software system set up on your computer. You don't even have to dictate on a phone anymore. You just start talking to the patient and you do your physical examination and you speak out loud. Hey, lungs are clear. Hey, heart is regular. Abdomen is soft and non-tender, and so forth. And this system will just automatically detect your voice and incorporate that information into a note. And you just review at the end, make smaller edits or whatever. And that's less documentation and more time you can spend taking care of patients. So I think we're headed in the right direction, and I'm excited to see how, things will shape out in 5 years, 10 years. It'll be so much different than how things are currently.